Well, welcome back, everybody. Welcome back to the Learning Symposium. This is the session on addressing social determinants of health. My name is Carol Moser. I am the Executive Director of Greater Columbia ACH. We have a great panel for this session. But before we go into addressing social determinants of health, I'd like to put everybody on the same plane, the same level playing field, in terms of defining social determinants of health. The CDC definition of social determinants of health are those conditions or circumstances in the places where people live, learn, work, and play that affect a wide range of health and quality of life risks and outcomes. So given that definition, we have a few housekeeping rules. So first of all, I'm going to take you through those. The audience is muted and your video cameras are turned off. You should only see the panelists and slides when they are shown. If you have technology issues, please put them in the chat. There's only the chat option to chat with the panelists, not the entire audience. Our tech gurus will see your chats to the panelists and we'll get back to you individually also via chat. If you have questions for speakers, please use the Q&A box and we will do our best to get to those questions, as many as possible. Both the chat and the Q&A function should be at the bottom of your screen. And we're recording all of these sessions and copies of the slides will be available on the website after the third day of the symposium at www.washingtonach.org. And now, let me introduce our wonderful panel. First, we'll hear from Amy Brandt, who's the Communications and Special Projects Coordinator for Olympic Community of Health. She will be followed by AJ McClure, who is the Deputy Director at Global to Local. Prior to Global to Local, AJ held community engagement roles for the City of Seattle, King County, and a variety of community-based nonprofits. Then Craig DeBlanco, who is the CEO of Coastal CAP, a community action program in Grays Harbor and Pacific counties. Also with us today is Leslie Nairmore. She's the Executive Director of Washington Gorge Action Programs, a community action agency which serves Klickitat and Skamania counties. And finally, joining us is Pamela Joyner, who was recently appointed to lead the COVID-19 Vaccine and Care Coordination Project within the Prevention and Community Health Division at the Washington State Department of Health. She previously served as the Director of the Office of Health, Healthy and Safe Communities. Each of our panelists will share a brief overview of their work, and then we will move into a discussion with some of the Q&A for the last 15 or 20 minutes of this session. And with that, let me turn it over to Amy.
Thanks, Carol. I have a few slides, so whoever's working the background, the magic. I could go ahead and get started introducing myself as they get the slides shared. Here we go. So my name's Amy Brandt. I'm the Communications Coordinator at Olympic Community of Health. Olympic Community of Health is the accountable community of health in the Olympic region. We work with Clallam County, Jefferson, and Kitsap County and 7 sovereign nations. So go ahead, next slide. I'm really excited today to share with you some of the work that OCH has recently done to better understand and begin taking steps forward to address these really tough issues that no single sector tribe can tackle alone. And by those tough issues, I'm going to be talking about determinants of health. So over the last year, Olympic Community of Health partnered with Collaborative Consulting to begin a research project and to explore some opportunities for region-wide collaborative interventions to address determinants of health and social needs specific to the Olympic region. So we began by doing an environmental scan and assessment. We sent out a survey to all of our contracted partners, and we received 38 responses that gave amazing insight as to where our partner priorities are at, what current projects are happening on the ground that are addressing social needs, what social needs would they like to address, but currently don't have the support to do it or the knowledge, and areas for collaboration and partnership. We also conducted a literature review where we looked at 25 case studies with different success models that we could then bring to our partners and see what would be a good fit for our region. And lastly, we took stock of available local data to continue to paint that picture of what's happening in our region and better understand which social needs are impacting community health. So we took all that data, we had so much information, but we wanted it to be useful, accessible, and meaningful for our partners. So we created various reports of all sizes. There's one for everyone, kind of like Goldilocks. We've got a very large report and we've got a super short highlight report with just the key takeaways. We wanted the information to be available to partners, but also something that they will access and use and understand. But we didn't want to stop there. We wanted to continue the conversation and invite our partners in to discuss these findings. So we hosted 3 virtual convenings in July, one in each of our 3 counties, to discuss the findings and begin to identify next steps in areas for collaboration. We had 72 participants, and it was really an amazing opportunity to lay a foundation and level setting of shared language and understanding of why it's important to even be talking about determinants of health, let alone addressing them from a collective response. Next slide. So I want to share briefly a few key takeaways from our findings. So what we learned about social needs. We learned the top 3 social needs from the perspective and experience of our contracted partners are housing instability, financial strain, and transportation. And I just want to emphasize the interconnectedness of these social needs and the way that they impact one another. So by addressing one social need, it's going to have a ripple effect and begin to impact others. So if we start addressing financial strain, it'll have an impact on housing instability and transportation. All right, next slide. We also, in our survey to our partners, we got insights about priorities for action. This graph I find really helpful. There's a couple of moving pieces to it. So as we move from left to right, it shows what social need will have the biggest impact on community health. So my eyes are directly drawn to the furthest right. We've got housing instability as the social need that would have the largest impact. And as we move from the bottom to the top, it shows how easy it is to address these social needs. So at the top, we've got food insecurity as being one of the easier ones to address. Still difficult, but easy compared to some of these other ones. And if we look at our friend, the housing instability in the corner, that one's pretty low on this chart, meaning it's quite difficult and challenging to address. And also we have the size of the bubble, and the bigger the bubble, the higher the response about priorities that would benefit from a collective regional response. So once again, the biggest bubble goes for housing instability, which means that it would benefit from an aligned response, people working together and just collectively responding to this, as opposed to everyone going their separate directions. So this really informed where priorities are at and where we can move forward. So next slide. So Olympic Community of Health is just getting started in this work. These research activities and the conversations we had at our convening has informed where we're headed in the future. So currently we're working on a region-wide inventory of determinants of health work going on in the Olympic region. And once we have this inventory complete, we'll be able to identify where the gaps are at and where there is opportunity for collaboration and partnership. We are also committing to host a housing summit in 2021, which we're really excited about this opportunity to address that top social need, housing instability, and provide a space and opportunity for collaboration, problem solving, and success sharing around this topic. And we always encourage community clinical linkages. So the partnership between community-based organizations and our clinical providers to tackle these topics. We've worked it into the way that our partners set up their work plan so that they are actively looking for new partnerships with the community. And expanding that table, taking stock of what voices are being accounted for and taking notice of whose voices are being silenced or are not present in the conversation. So we are, this type of work, it's so important to just pause and then take intentional efforts to create a space that's comfortable for people to join in this co-creation process that John Powell talked about yesterday. And lastly, we're going to be working on a community resiliency toolkit to really equip our partners in the community with tools that can build workforce and individual resiliency, especially during COVID-19. This work is hard in any time, let alone during a pandemic. And we just want to continue to support the resiliency and the motivation that will keep this work going. So thank you so much. I'm so grateful for the opportunity to share, and I'm looking forward to hearing from the other panelists.
Great. Thanks, Amy. Next, we're going to hear from AJ.
Good morning. My name is AJ McClure, and I am the Deputy Director at Global to Local. We are a community-based nonprofit in SeaTac, Washington, focusing on health equity and addressing both the culturally appropriate services and tackling the structural issues that lead to disparities, mostly in SeaTac and Tukwila, but we partner and serve clients in broader South King County. Today, I'm going to talk about Global to Local's work with Healthier Here on the Community Information Exchange, also known as the CIE, as we like to call it, and how we see it transforming the way we address the social determinants of health and how we see it advancing equity for a healthier future. So I'm going to go a little bit, I'm going to approach this a little bit differently, actually, and actually share a personal story. And I think we have some slides. I don't know if those slides are being shown right now. So, and I asked you to indulge me here a little bit. So the focus of our work with Healthier Here is addressing the social determinants of health, eliminating barriers for clients, and addressing the social and increasing access to services so we can better serve our clients. Embedded in that is some work that we've identified, and that's going to help us identify where those system gaps are in terms of the structural issues that lead to the barriers and the disparities that we see in our community. And I'm going to connect that to kind of what's going on in our broader community in regards to COVID and in the social and racial justice movement that we're seeing across our country and across the world, actually. But I had an interesting call last night, and I'm a little bit distracted about that, and I was up all night thinking about it, and it's actually funny because it directly relates to what I wanted to talk about today. Over the weekend, I found out yesterday my cousin was pulled over as he was taking his kids out to a pumpkin patch out in eastern King County. He's Black, and he had a 7-year-old and a 6-year-old nephew. He was pulled over by police for going 42 or 48 in a 40-mile-per-hour zone. He had to sit there for 35 minutes. Another cop car comes in, questioned about the car he was driving. He was borrowing my cousin's car, asking about the relationship with the kids, and sitting there for 35 minutes not knowing what was going to happen. Now just think about that. Think about the mental stress. Think about the anxiety that a person would feel in that situation, given everything that's happened in our country over the last several months. That is exactly what we're trying to address here. When we talk about the social determinants of health, it's about addressing people's needs, right? Meeting people where they're at, providing the services and the supports that they need. But the larger issue is the structure and the system in which we're working, right? It's not broken. It was created this way, right? So I just wanted to share that story because it's gonna follow along kind of where I'm going with this. So we'll go to the next slide here. And I can't see the slide, so I'm not sure if we're on the second slide here, but it talks about our connection desk, Global to Local's connection desk, where we serve. It's a no barrier walk up for clients in the community to come in and address a multitude of needs. Our value proposition for this program is that No appointments are needed. Anybody can access it. They get culturally appropriate services to a variety of supports and services. And then we try to integrate that in various spots of the community. Due to COVID, our numbers here that you'll see, these are from last year. We've had to scale down the program and adjust where it's going to be located based on COVID. But our mission is still the same: is to create access to people in the community, provide the support that they need in culturally appropriate ways, and integrate that in various spots of the community. Next slide, please. And so our partnership with Healthier Here is focusing on the CIE and the community information exchange. And then in this slide, you'll see the kind of the nuts and bolts and the foundation of our connection desk. It's to eliminate barriers, provide culturally appropriate engagement, provide whole person care. But where the transformation really happens with Healthier Here and the CIE is the connection to services. Over the years, as we've been running the connection desk, we've served thousands of clients coming in, getting the support, getting the information, getting the referrals they need, but we've lacked the capacity to really see where they go, right? And to ensure that they're getting the services and the support that they requested. The CIE adds that capacity, adds us to a network of other partners, service partners in our area that share the same goal and the same vision of addressing client needs and focusing on reducing those barriers. Next slide, please. And so, so this is kind of where I go back, where I'm going back to how this is transformative for our future. We're 2020 and COVID-19 has clearly flipped our world upside down. It's basically revealed to us what we've already known, and that people of color, communities of color, are going to be impacted by this pandemic disproportionately than other communities. And so now this is our call to action, right? This is our time to act. And if we go to the next slide, combined with that and the movement around racial justice and social justice, this is, if there was ever a time to be strategic and marry those worlds of service provision and system change, this is the time, right? And to do so with a laser focus on focusing on racism and dismantling that within our systems. Going back to the story about my cousin, it was the fact that he got pulled over, right? It was the fact that that was part of it. But I'm thinking about the personal experience. This is a man, a father that has had mental health issues, and for him to have to sit there for 30 minutes, 35 minutes, and wonder what could happen here. Just sit with that for a second. And that is a result of the work of our system and how we and how we operate and how it governs and how it serves or doesn't serve the people in our community. So this is my last slide. So going back to the CIE, we see this, Global to Local sees this as an incubator for system change, right? It's going to allow us to see where the gaps of services are, where the structural gaps are, so that we can mobilize as a community with our partners to really focus on that systemic change that we need to see in our community. Thank you for the time here. Thank you for indulging me on my personal story. I just felt that it was so relevant to what we're trying to get at here in our community. And I'm happy to answer any questions about our program in the Q&A. Thank you.
Thanks. Thank you, AJ, for sharing your story. Now we're going to hear from Craig.
Unmute myself. Thank you, Carol. Good morning, everyone. It's great to be here. I as well have a slideshow, so hopefully that'll pop up. Yep. And we're gonna move pretty quick through stuff here. If you want to go to the second slide, that'd be great. So I'm Craig DeBlanco, the CEO of Coastal Community Action Program. We serve Grays Harbor and Pacific counties, and we have a history of really fighting on the front lines of the social determinants of health through housing and many, many other programs. The program I'm going to talk to you about today is a partnership between us and our accountable community of health, Cascade Pacific Action Alliance, and it's very exciting. So if you want to go to the next slide, we'll dive right into it. We started out really focused on Initiative 3 of the waiver, foundational community supports program where Medicaid was paying for housing support services and employment services for homeless individuals. And I'm going to tell a quick story here. What happened was we were focused there, and then our CPAA decided that care coordination was one of their priority areas that they were going to focus on within our region. And so I signed us up for that, not wanting to miss out on something, had no idea what I was signing up for. And they created a committee, and Michael O'Neill led the charge from our ACH CPAA, and he began to really dive in and explain a little bit about this pathways tool that was going to be used. I was getting a little bit of it, but I really didn't understand all of it. But what happened was we hired a new manager in early 2018. And he came to me shortly after being here and said, hey, what is our tool that we use to solve homelessness in people's lives? And I said, well, we have rent money. And he said, no, but what's the tool? There's got to be a tool. The state is throwing millions of dollars at homelessness. There's got to be a tool that agencies are using. And I said, well, we case manage them a little bit, and we have rent money. And he couldn't believe that we didn't have a tool. And then he went to a statewide homeless conference in May of 2018, and he called me up and he said, hey, nobody has a tool. Everybody just uses rent. And we then had a fire in June of 2018, and we lost everything. And that's important because it allowed us to, it forced us to break everything down and rebuild. And what happened in our rebuild was in July of 2018, we got this email from Michael saying, hey, the first training to be a Pathways care coordination group is in early July. And that was really hard for us because we just lost everything. Time was at a premium. We sent our new manager to that, and he called me after day one and he said, Craig, this is the holy grail. This is the piece we need to successfully help our clients transition from homeless to success in their life. And I want to say one more thing before we move on to the next slide. What we have in our communities, we see about 100 people through coordinated entry every month. About 50 of those are brand new to the system, and 50 we've never, that are kind of repeat. So 50 we've never seen before. Of the people that come into coordinated entry, we have rent money for about 25% of them, which means that 75% of the people we don't have rent money for, and those people still need to be able to be helped. And that's where our partnership with CPAA and the Pathways program, which they call Community Care Board actually, but I call it Pathways still. But the Pathways program is making a huge difference in people's lives. You can switch to the next slide. I apologize, I'm talking so fast, but I really want to make sure that we hit some of this stuff here. Yeah, so go the other direction on the slide. So one more there. Oh, nope. One more. There we go. So what? There we go. Here we go. So what we did is we decided in our rebuild of this, and we worked very closely with Michael at the CPA and our local county, Grace Harbor County staff. We worked very closely with them, and we decided to fully integrate Pathways from the moment somebody walks into our door as the coordinated entry site. And now we are looking at 20 different pathways in their life from the moment they walk in. So whether we have rental assistance dollars or not, we were able to start solving problems in people's lives. And we believe it's been amazingly successful. So people come in to coordinate entry, we connect them with a Pathways program, a care coordinator through that, and we use foundational community supports dollars and other rental assistance dollars to help pay for all that. Then one of the things I wanted to note is one of the keys to all this was you go through a very extensive training process with, in our case, with our CPAA, our ACH, and that has been helpful because we were able to hire a whole bunch more staff, but the effectiveness before it ended up being how good was your care coordinator. That translated into how fortunate you were going to be in terms of your help you got from us and all that. But now it's leveled the playing field because all of our care coordinators are using the exact same tool for success, and it's been great. So go ahead, next slide. I'm going to continue to talk fast here. We use Pathways as a tool to inform care coordination. Apologize for the typo. Is an evidence-based tool that absolutely makes us better. It's client-driven and client choice, and they're working very closely with their care coordinator, whether we have rental money for them or not. And that's one of the big keys. Go ahead, next slide. Yeah, I apologize, I'm moving faster, but we believe that Pathways has done the following for us. It's improved engagement in mental health and substance use services, improved engagement with primary care versus ER and those types of activities. Healthcare needs are addressed earlier so that it becomes preventative for them. Homeless clients are staying housed longer and reaching independence faster. We're seeing a reduction in incarceration and deeper engagements in supports such as familial and social and a whole bunch more. There's only so much I could do in this short time, but those are really real. Go ahead to the next slide, please. I want to really talk about, just for a brief moment here, our CPAA's role. Michael and his team have been fabulous. What they did is they create a hub and a group that we could work very closely with, and they're very involved in our success as an organization. They designed the whole system, customized it for our region. It's also a platform for interagency partnerships. So we're working with a lot more agencies than we used to. Their training program is absolutely comprehensive. It's very detailed, very successful. Our staff, we've brought on about 20 or 25 new staff since we started this, and all of them are fully trained and operating in this at a very high level. And then they give ongoing management to us that is just that we're working together all the time. It's a very good partnership, and we couldn't do it without them. Go ahead, next slide. Oh, that's it, great. All right, so I tried to be fast, the short timeline, but I'm happy to answer any questions that might come up as we go on.
Thanks, Craig. You're obviously very enthusiastic about your program. It's just great hearing about it.
Thanks.
Thank you. So next we're going to hear from Leslie.
I'm going to talk to you today about how the social determinants of health work in a rural setting and how that work ties to our Pathways Care Coordination Program, which we work in partnership with our local ACH Swatch on. So for our agency, this work and the work of Pathways has been just absolutely life-altering for the clients that we serve. Living in a rural setting, we don't have much by way of public transportation, and people often live miles from the nearest town. And that's further complicated right now with COVID. We also have the issue of having poor cell service or sometimes no cell service at all. Our community health workers are able to go directly to the clients where they are and work with them in settings that the clients are comfortable in. And they can also help a client with transportation when they don't have any other options. When clients initially come into the Pathways program, our community health workers perform an assessment with the clients, and then based on those answers, they decide together with the client how they're going to get their needs met. So they provide the service of helping people navigate systems, which is an overwhelming thing anyway. I don't know if you've ever tried to sign up for health insurance, but now imagine that you're doing that and you spent last night outside, or you don't know where your next meal is coming from. When my agency began the journey of becoming trauma informed, this is where I imagined that eventually someday we might end up meeting clients on their own terms and not making them conform to certain expectations to receive services. And don't get me wrong, it's not a free-for-all, but we're able to maintain much greater flexibility in the way that we offer services. It can be really frustrating in social services when you see people failing out of the system through no fault of their own, especially when we know that those systems are based on and built on inequity. You know, maybe they don't meet certain criteria, they don't have identification, they aren't signed up for Medicaid, they don't show up for appointments on time. These are all things that we can help them with. So I'm also going to share a story. One of my favorite stories that was recently relayed to me by one of our community health workers is that she was working with a client who was trying to regain custody of her children. And the first step in that plan was being able to maintain visitation, but the visitations had to be supervised. So the community health worker was able to become certified to supervise those visits so that the client could maintain contact with their children. And then they were also able to help them with transportation. And I can't think of a more primal and necessary social determinant of health than being able to maintain contact with the people that you love. So for that one client, we were able to completely change everything for her because she could continue to see her children. And we also work closely with our medically assisted treatment, our MAT program, and we're seeing people who've hit rock bottom just completely turn their life around. We don't have inpatient care available for people who have substance use disorder in our area, so this is a really good alternative to that. And I just have to give a shout out to our local hospital, Klickitat Valley Health. We're so proud of them for having this really just groundbreaking program available in a small rural community. And in our Pathways program, we have seen such great results that we have now expanded that into our housing and our homeless programs, kind of like Craig's agency. And we now use it as a case management tool in those programs as well. And we've also partnered with other community-based organizations and our local school district. And the school district now has family health advocates who work with families in the same way that a community health worker would. And they're able to provide whole family wraparound services to families who are struggling, especially now with the added burden of COVID-19. And as part of that, this new group has also started a community of practice. So we have community health workers, our family health advocates, and then the families who are receiving services all at the table. And I think this is so important to have that piece where the people who are living the experience are able to give feedback. I think so often we as service providers, and I'm including myself, we tend to forget our own privilege. And we think that we know best based on our own experience, what we've seen work for somebody else, our own biases. But you don't really know until you've lived it. And so I think one of the most important aspects of this program is our ability to be able to give people agency. And then we're there to help guide them, but we let them make their own decisions. And so I am so proud of this program, of my staff who are bringing it to the people. And I just feel like we are so very lucky to have this program available in our community. So in closing, I would just like to say this, we don't have huge numbers. We're a small community, but we do have huge stories. And for us, this program has made all the difference in the world for us and for the clients that we serve. So thank you very much.
And thank you, Leslie. Empowerment is a wonderful thing. So thank you for giving that to your organizations and your people. Lastly, we're going to hear from Pamela Joyner.
Okay, can you hear me now?
Yes.
Okay, great. We'll go ahead and go on to the next slide, please. So today I want to share with you some of the work we're doing that is addressing social determinants of health as part of our approach in addressing the COVID-19 pandemic. Department of Health has a shared interest with partners in addressing social determinants of health with a focus on equity, and that includes a desire for leveling the opportunity for those most impacted by the pandemic to have access to resources to support isolation and quarantine. For public health, this is a particular challenge for a number of reasons. The department was asked to stand up a system to support home-based isolation and quarantine for the state as a component of its box in the virus strategy. We were first given funding to initiate implementation in Yakima, a county with very high case rates for reasons related to inequities, including occupation, language, access, distrust of government, ineligibility for some services because of immigration status, etc. DOH is committed to supporting and engaging with the local community-based workforce as a way to build trust and transcend culture and language barriers, serving anybody in need, connecting them to services for which they are eligible, and filling in gaps, being accountable for the resource distribution, and assessing whether the resources are helping us to meet public health goals in these most impacted populations. Next slide, please. CareConnect Washington is an innovative public health utility model that leverages state and local partnerships to provide coordinated, person-centered, community-based responses to our most critical public health challenges. The focus is on the community-based workforce and workflows and tools that can be influenced by them to best meet the needs of the populations they are serving. It's a systems approach to solving problems with ways of tracking accountabilities, including the equitable distribution of resources, support for everyone who needs it, and placing resources in areas of the state most in need. We're also providing a data system tool that's available to everyone at no cost to the primary users of the system. Next slide, please. This slide shows CareConnect Washington's reach since quickly pulling together a small team within Department of Health in early July. That was three of us working on a weekend to putting contracts in place in Yakima, Benton, and Franklin counties that began in mid-August and early September, respectively. What we've heard from the contracted care coordination staff reflects the extreme needs being met by many individuals and families in communities across Washington who are disproportionately impacted by this disease. What we're hearing directly from care coordinators as we meet with them on a weekly basis is that there's amazing work being done for communities. Individuals and families are so grateful for all of the support. Everything is working well. The workflows for care kits, food kits, and referrals to services are really great. The care kits and food kits are working, still helping families as needed, still keeping communications with clients about the household assistance that is being provided to ensure they know on a weekly basis the timeline and updates, which relieves any anxiety that they may be having. One recent story is the care coordinator received a household with a mom and 2 children. The care kit was delivered directly to the family along with a completed food order. All were delivered within 1 day. At 8 a.m. the next morning, the care coordinator had a voicemail from the client who was crying because she was so grateful for the supplies and the food she received and received it so quickly. Lastly, now that the program is live in that community, the community is becoming aware of the program. Through word of mouth about the program is spreading, and they're hearing and seeing that they are building community trust through this process. So those are just a few examples of this effort going on in Yakima and Benton Franklin counties, and we're very excited to be moving forward and expand out across the state in the coming months. Thank you.
And thank you, Pamela. You really opened the door to our first question for our panelists, which is how has COVID-19 impacted your work? And why don't we just start right from the very beginning? So we'll start with Amy.
Thanks, Carol. COVID-19 has greatly impacted our determinants of health work at in the Olympic region. First of all, logistically, it's changed everything. Like all of our events have turned to virtual events. And also we're now dealing with Zoom fatigue, and people are, and if that's the only way to convene people, trying to find more ways to still provide meaningful information in a way that's useful and won't be overwhelming. So that's kind of why we're taking on the resiliency toolkit, is try to counterbalance this Zoom overload. But also just COVID-19 has exacerbated the social needs in our region. And we are a more rural region similar to what Leslie was talking about. And we're seeing COVID-19 really affecting isolation, and just a lot of the messaging that went out initially with COVID-19 around social distancing. People took that as no longer being socially connected. And when you're in a rural space, that really hits hard. So we're trying to provide ways to keep this work moving forward in a way that's responsive to the current needs, and also forward looking to, because COVID isn't going away tomorrow. I wish it would, but we're trying to be responsive, but also catering our approach to the specific needs of our region.
How about you, AJ?
Yeah, similar to Amy's organization's experience, you know, I think it's what it's forced us to do is we provided a variety of services in person, right? Providing physical activity classes, nutrition classes. Our connection desk, as I talked about earlier, was in-person walk-ups. Everything's had to go virtually, but more specifically to COVID, you know, we got into the business of going from providing like our community health workers facilitating and running physical classes to actually doing meal delivery and getting direct financial assistance out to people in the community for whether it be housing, food, car repair, right? So in some ways, we went from a direct service agency to a more direct service agency around specific basic needs. Because I think in Amy's slide, you know, they showed, you know, the chart that showed housing and food security. We have similar data related to our connection desk and the case management we do with our clients, but now that's just needed more than ever. And so as an organization, we had to basically scale up some of those programs to actually provide those direct services immediately. So that's how it's impacted our organization the most. And we are still in the midst of adapting in terms of what our long-term programs look like, because in-person activity is still far, you know, down the road.
Great. Thanks, AJ. Craig, you have another shot. How's COVID impacted your work?
Yeah, so what we did was, well, first of all, obviously it's tremendous, you know, the impact is enormous. But what we did is we built, we have a really big building. So we built 11 virtual intake rooms in our, we have an old bank drive-through. So we moved our reception to the bank drive-through kiosk that has bulletproof glass. And it's kind of a safe environment. And then we built 11 little 8x8 sheds and put a TV screen in there and a little webcam and a little table and a chair. And so people check in now and they go and get put into one of 11 rooms. And and so we were able to do that. But what happened was we found that we got a lot more creative in how we were coming up with solutions for people. And so as we worked through care coordination with the Pathways program, there are certain education pieces within the Pathways program. So we're able to use that and educate them. And we actually found that our business went up during COVID. We stayed open and we housed more people in the month of April as an organization than we had ever in the history of our organization in that particular month. That was the best month we'd ever had. And I think there was some fear with the clients. And so they were more open to responding to some of the education and some of the work our staff was doing. But also we were able to change the way we thought about connecting with our clients. And it was really good. And we were able to, it made us, I think COVID COVID's a terrible thing, but I think it made us better as an organization in terms of how we work with our clients.
Yeah. Great question. Great answers. Thank you. And Leslie?
Well, I mean, I can't think of a single thing that it hasn't changed. It's changed everything. And I think that it's changed the landscape of the world as we know it, especially our work world, forever. I don't see us, especially office work, I don't ever see it returning to the way that it was. So for us, we've had to be really flexible with staff because of having to work remotely, because everybody has their kids home from school. Everybody's trying to work while they're Zooming with their kids. They have Zoom fatigue. I mean, it's just everything. But a few things that we've done to try to work through this is at least in like our food banks, those are now drive-throughs. So they don't have to come in the building. We bring the food right out to them. But I think probably one of the biggest ways that it's been detrimental is that social connection. So for so many of our clients, we are their social. We are, you know, they would come in the food bank. Sometimes we'd have samples, they'd chat with each other. And that was their social connection for that week. And they don't have that anymore. So trying to maintain that, you know, try to do it over the phone, you do what you can, but that part has just, I think, been the most difficult.
Okay, thank you. Pamela, I'm going to flip to a question from the audience, and this is from an MCO. I'll read it here. It says, as an MCO, we work directly with providers and the healthcare authority to ensure quality care to our members. Learning about the work being done through the ACHs is paramount to collaboration on our work. So how do you see the role of the MCOs in working with the ACHs? How can the MCO partner with your organizations to help deliver equitable care to the Washington community, especially for those with the largest disparities in equity, that is homelessness, dual diagnosis, substance use?
So let me respond to that from, again, the care coordination system we're setting up for COVID specifically. And this is a great opportunity, I think, and example of the leveraging of the partnerships and the resources that our individual organizations are able to provide to individuals and households who have tested positive or come in contact with someone who's tested positive, to assure that we're using all of the resources to the best of their ability. And so as we begin to work through our efforts and understanding, for example, with the MCOs and knowing that they have care coordination funds available to support their members, and we don't want to be duplicating that with our resources, being able to share the data and understanding who we're serving so that, again, we have more resources available out into the communities to address those inequities.
And Pamela, are those care kits culturally tailored then to the specific community groups? And what do they?
I would like to say that the food kits, so there's two different types of kits. There's a care kit, which is like personal PPE, gloves, masks, acetaminophen, a thermometer, liquid hand soap, and sanitizer and wipes. Those are in the care kit. The food kit, because we're working with a national partner, Kroger's, and they're providing food kits across the nation, we cannot be as curated as we would like to culturally. Had conversations about that with them, that because of the scale of items that we're buying, it's more challenging to have them be specifically appropriate for specific populations, because it is just a very short-term amount of food for just a couple of days until fresh food that can be more, which is more culturally appropriate, be delivered. So, for example, in Yakima, we are working with a local grocer there, Fiesta Foods, and they've been able to step up and meet those specific food items for the community that they're most comfortable with eating, versus getting a food kit, which might look pretty bland.
Okay, great, thank you. We talked a lot about how difficult it is to provide housing for people. I'm going to flip this question to Craig. You can start with this one. So some social determinants of health are considered low-hanging fruit, and there's other ones that are more difficult to address. From your experience and perspective, where should we be prioritizing and devoting our time, energy, and resources?
Yeah, good question. So, I mentioned that we have 25% of the people that come see us, and I think this is probably true statewide, that we have rent money for. There's not rent money for everybody. And so when people come into our organization, they don't come for a warm hug. They don't come for somebody to talk them into whatever. They come for rent. The problem is only 25% of the people do we have enough rent money for. And again, if that's even if it's close to what the statewide average is in terms of the number of homeless people that are walking into organizations like ours, the low-hanging fruit is the 25% that can get rent. The question is, how do we serve the other ones? And what we have found, and I hate to just keep coming back to it, but I am a firm believer that we have to have a system in place statewide for how we're going to treat homelessness as a condition. And we have found, there may be others out there, but we have found that Pathways, and in Initiative 1, if you go into the care coordination, in the original Healthcare Authority guidance, Pathways was the tool that was the recommended tool for care coordination for the state of Washington. And I think that one of the keys is using an evidence-based tool to solve those areas in people's lives. And in the case of Pathways, it's actually an incentive-based tool, so that, excuse me, when we have success with somebody, we actually get paid for the success as they hit barriers. So that motivates us, and we in turn are motivating the client, right? And we're seeing a significant increase in success. But I think I want to make sure I really emphasize the evidence-based practices. A lot of times, I've been doing this for 21 years. I've watched this for a lot of years, and I don't want to speak against any of our care coordinators because we've had great ones, but sometimes life is complicated, right? And these people are coming in with many different issues that they're dealing with. And what we were able to do with Pathways is take a single tool and systemically start working with them. And it's client driven, so they were able to engage and really own their stuff. And if I could just say this for the MCO question, if the MCOs would partner with the ACHs on a tool statewide, it's almost remarkable that we really don't have a tool. In mental health, we have a tool. In substance use, we have a tool. We should have a tool here. And I think that's a great way for us to partner. Sorry, it's a little bit of a shameless plug there, sorry. But I think that's the answer.
You're getting applause from the panelists. Amy, what do you think? What's the low-hanging fruit? Where should we prioritize?
I think it's a balance of both taking opportunities to address the low-hanging fruit, the things that are easy and will have an impact on the community, but also moving forward with some of those more challenging things. So like housing instability is the biggest thing in our region and one of the most difficult things, but that doesn't mean there's not solutions out there. So while we're doing some of the more low-hanging fruit stuff, we're still pushing forward with bringing partners together to talk about and collaborate on solutions to move forward with some of those more challenging things. So I think it's a balance, and I think it's important to be optimistic about things and be creative, think outside the box, but still honoring your own organization's capacity and reaching out for help. That's where that collaborative approach is really strongest, because it takes the support of a whole region, both community-based clinical providers, to tackle some of these more difficult, higher up fruit.
Thanks, Amy. What are your thoughts, Leslie?
Well, I don't know that we have low-hanging fruit. I mean, You know, just going back to what Craig said about how they have so many people come in and they don't have the rent money. Well, we have the opposite problem. We have plenty of money and no housing stock. We are here in the Columbia River Gorge, which is a destination. A lot of people want to come here. A lot of people have second homes here. And so I think, you know, it's not necessarily low-hanging fruit, but it's necessary. And we try to advocate at every opportunity that we have for affordable housing, not just more housing. You can't just build housing and then expect that it will trickle down. That does not happen. So just advocating at every opportunity that we have for affordable housing to be built, we have to increase our housing stock.
Couldn't agree with you more. AJ, and then finally Pama for this same question.
Yeah, I don't know if I would call it low hanging fruit, but I would also say that, based on the impacts we've seen on because of the pandemic, specific to housing, we're seeing things like, the moratorium, right, on evictions, things that were told to us that worked in housing years, over the years that can't be done, right? But now are being done. So the system has adapted in some ways to alleviate some of these conditions and some of these impacts on the communities we serve. So I think the low-hanging fruit, or I should say the opportunity that exists, is how do we capitalize on some of that, right, from a systemic change perspective. And I think because of that, we've seen, ways, or we've uncovered ways, and I'm speaking mostly through what I hear from some of our partners that work specifically in housing, that there are things that they can do around tenant protections, around tenant support, around access to legal assistance, for tenants that weren't necessarily clear. The path forward wasn't necessarily clear before COVID-19. And so now we're starting to see that. And I think there's also a heightened awareness around that from a funding perspective. So now funders and local government, even through, in King County, we're fortunate to have some of the resources to actually tackle some of these issues. So when it comes to housing, I think there are some opportunities based on the impacts of COVID that we can mobilize around.
Great. Thanks, AJ. Pama, you want to wrap us up with this topic?
Sure. So I think, in terms of the low-hanging fruit, what Department of Health can do and be available for is really engaging with the communities and better understanding what their needs are and meeting them where they're at, and identifying the resources we have to address, and also being able to carry that message back to other initiatives that are taking place. When you think about the poverty reduction work group efforts that are in play right now, and really promoting the messages that we're hearing through our efforts, along with the community voices that are at the table on that poverty reduction work group, position us all to work better together to address those needs, so that once we've got the low-hanging fruit addressed as best we can reach up higher into that tree.
Great. Well, I could talk about homelessness all day. As a former elected official, I really think that every community should be responsible for their populations, and especially their homeless populations. And unfortunately, the rules and regulations around housing vouchers don't necessarily follow that pattern. So anyway, it's been great. I really want to thank all of you guys for joining us this morning. We just have a couple of minutes left, and just as a reminder that the recording of this session and the copies of the slides and other materials will be available on the ACH website by the end of this week. And we are now going to take about a 15-minute break before our next session. Thank you for joining us.